Portugal. And my co-chairman is Professor Howard Darius from Germany. As you know the rules, each speaker will have 5 minutes for presentation. We have 6 presentations today, followed by 5 minutes for questioning. We do have 2 spokespersons that will be available for any independent comment after the press conference, and they are here on the front row, Professor Michel Bertrand and Professor Helmut Schulen. If you don't mind, just stand up and say that who you are. And without further ado, we will start immediately with the first presentation. It's Professor Nicolas DANCHIN, and he will present decrease in early mortality in STEMI, attributed to changing patient profile and behavior and improved organization of care. This is data from 4 French registries over 15 years, and it's called the FAST-MI. So, Nicolas.
Thank you very much, Fausto. Ladies and gentlemen, it's my pleasure and my privilege to present these data from French registries of acute myocardial infarction. I have been the principal investigator for all 4 registries that I will show you, and which were carried out from 1995 to 2010. The first 2 registries were funded by late pharmaceutical companies, Roussel and Aventis, which were later swallowed by Sanofi-Aventis. And the last 2 surveys are surveys from the French Society of Cardiology, and they have been funded by unrestricted grants from the companies that you see listed here. And I take this opportunity to thank them. The idea behind these surveys was to try and determine what the patients sustaining a heart attack, that is in our jargon what we call ST elevation myocardial infarction, looked like, how they were managed, and what was their outcome. So what we know from other studies is that in the past 10 to 15 years, there has been a decline in STEMI mortality, and it is usually attributed to increased use of reperfusion therapy being the ways we use to reopen the blocked artery which causes the heart attack. We sought to determine within these 4 sequential registries, which were carried out 5 years apart each, whether other factors such as temporal changes in patients' characteristics influenced changes in outcomes beyond the only use of reperfusion therapy. You see here the 4 surveys, the description of 4 surveys. In all, we had 6,700 patients included. And as you will notice here, there was a decrease in the number of participating centers, and that was because the French health authorities encouraged the institutions to regroup in order to have larger centers treating the patients who had heart attacks in France. Overall, the participating centers represented from one survey to another between 60% and 75% of all institutions taking care of AMI patients in France. The first thing that we noticed and came as a surprise to us was that the mean age of the population decreased during this 15-year period of time from 66 to 63 years, and that was due mainly to an increased proportion in the younger age group, that is less than 60 years of age. It increased in men, but mostly it increased tremendously in women, actually doubled from 11.8 to 25.5%. And that was in relation with changes in some of the risk factors, and in particular current smoking. It didn't change much in men, but as you see here in younger women here in red, the proportion of current smokers at the time of their MI increased tremendously from 37 to 73%. And there was also an increase in obesity, which was found in all age classes in men, but mostly in younger women, as you see here as well. There were also changes in patient behavior, and in particular the way the patients reacted to the chest pain they felt at the beginning of the heart attack. And between 2000 and 2010, the mean time delay between the onset of pain and the time where the patients called for help decreased from a median of 120 minutes to 74 minutes. There was also more use of the mobile intensive care unit system that we have in France, which actually more than doubled from 23 to 49%. Once in hospital, there were obvious changes in the management, beginning with reperfusion therapy. You see that the percentage of patients who got no treatment to deblock the artery, to reopen the artery, decreased by half from 51 to 25%, and that was linked to a major increase in the use of primary PCI from 12 to 61%. As for IV fibrinolytic treatment, which is another way to dissolve the clot with an intravenous medication, it did decrease from 38% to 14%. The evolution of 30-day mortality was absolutely striking in that we observed a 68% reduction in 1-month mortality from 13.7 to 4.44%. That is a huge decrease, and it was regular over time from one survey to the other. We did a kind of statistical trick to try and account for the change in the population characteristics, and we standardized the death rates of the first 3 surveys on the profile of the patients included in the last survey. And we had there these figures here. Standardized mortality decreased from 11.3 to 4.4%, and that means the difference here represents approximately 25%. That means that 25% of the observed reduction in mortality could be attributed to changes in the profile of the population sustaining a myocardial infarction. And overall, when we took into account all elements, including reperfusion therapy, there was a 61% reduction in the risk of dying from heart attack. And you see here that whatever the type of reperfusion therapy, lysis or primary PCI, or even in patients without any treatment to reopen the artery, there was a huge decrease in mortality, which was similar in the lytic-treated or primary PCI patients, but also very large, more than half in the patients who got no reperfusion therapy. So that were our main conclusions, and for those of you who may be interested, the paper will be published online in the JAMA today. Thank you.